Next, I think I'll hand it to Dr. Mouhanad Hammami to give us a state about the MENA group health. So I'm going to hand the mic for you, Dr. Hammami.
Thank you very much, Maha and Madiha, and everybody that is involved in this. I think this is a great event and a great opportunity to reconnect and revisit some of these issues. Alex, I believe you're going to be driving the slides, so if you can. So what I'm going to try to do in the next 15 minutes, which is certainly not enough time, but as Dr. Thompson mentioned, this is a teaser for things to come. So hopefully I'll give you enough to talk about what Maha very eloquently set the stage for in talking about people that live in the Middle East and North Africa or in the MENA region, then talk a little bit about the refugees and those that came from that region that are residing right now here, which are immigrants, but we refer to them now mostly as Arab Americans. So next slide. So risking that I'll be preaching to the choir, it is good to level us and set the stage for when we talk about equity, that this is not a new concept. Abraham Lincoln in 1863 referenced all men are created equal, and I'm sure he didn't mean that only men. He probably was looking more at mankind. Next slide. And it is also something that has been, even before Lincoln came up with that idea, it has been something that was brought up in different religions. This is from the Prophet Muhammad, that all people are equal as the teeth of the comb. And if we look at the next slide, also the Bible mentions that rich and poor have this in common: the Lord is the maker of them all. So we are not inventing something new. However, we seem to be very bad learners from history and such not good students when we are falling into the same mistakes. Next slide. And many of you have seen so many variations of this slide, but again, it is good to keep it in mind that when we talk about equality, then we do not mean equity. And when we talk about equity, then we are talking about opportunity as giving people what they need at the right time and not giving everybody the same thing. And if we want to take it a step further than justice, and now we're talking a lot about social justice, then it's removing the barriers of making people unequal or not preserving equity. Next slide. And inequities are found in all the population that is at risk. So ethnic minorities, racial minorities, people that are poor, people that are vulnerable, people that are homeless, people that have disabilities, people in certain geographic locations such as rural versus urban, people that are victims of political turmoil such as refugees, and also people that are discriminated against based on religion, based on sexual orientation, based on origin and all that. Next slide. And if we look at the determinants of equity, these are very well known to many of us. And when we talk about the social determinants of health, which we will explore later on, but we talk about the determinants of equity, then the common theme is access to affordable healthcare, access to quality education, access to public spaces and physical activity, access to safety, and access to opportunity, as well as the driving factor is the economic prosperity and the equity in distribution of resources. Next slide. So if we start honing down on the Arab world as a region compared to other regions, then the Arab world is one of the only regions where the expenditures on military is much higher than the expenditure on healthcare. And compared to every other region, even those that are in sub-Saharan Africa and in Latin America, then we see that the Arab world is the only country that spends more on armies and weapons than they spend on health infrastructure. Next slide. And what is very important to understand is that when we talk about the Arab world, we are not brushing with the same strokes. So even within the Arab countries, there are inequities and there are disparities. So if we look at the government expenditure on health, then as you can see, although very few spend more than 10% on health infrastructure. There are a lot that spend less, and not all are uniform. And the next slide is going to show not only how much per GDP countries are spending, but also the differences between those countries, which is going to relate to the outcomes regardless of how much the government might be using a buffer to minimize that effect. So if we look at Sudan, for example, and Yemen, the out-of-pocket expenditure for a Sudanese or a Yemeni citizen is almost 70% when they are seeking healthcare. And we know that that is going to translate to barriers to access to health. Compared to Qatar, for example, although Qatar spends less on health as a government, but the average expenditure per pocket for the Qatari citizen is almost 8%. So that is going to show you the differences in the health outcomes, and it has to translate into a disparity even within that region of the world where we might think as outsiders that everything is uniform and they all come with the same background. Next slide. The same is for socioeconomic indicators. And again, we're going to talk about the social indicators or the social determinants of health. But looking at Yemen, for example, and the GDP per capita versus Lebanon, for example, you can see the disparities. Looking at unemployment, where in Djibouti, it's almost 60% versus 8.4 in Syria or 8.9 in Yemen. And again, we know that employment and income and poverty and all that are essential in determining health outcomes and overall wellness. Next slide. And these slides, although they're relatively, the data is old, although it was published by the World Health Organization in 2014, but it gives us an example about health indicators and disparities within that region. So for example, infant mortality, Yemen has 81 per 1,000 versus in Syria, 17 per 1,000. Although these are two Arabic countries that are considered from the same part. And when you see two Arab Americans coming from those different countries, then it is very important to understand that they come from completely different health behavior and health risk factors and all that. The next slide also is going to show disparities in stunting in children. And if we look at other indicators such as skilled birth and delivery setting, or maternal mortality and all that, we are going to see that disparity as well. Next slide. Even if we look at the probability of death, and this is from the global burden of disease, not only the Arab world is different from other regions, but within the Arab world, you can see that the probability of someone dying between the age of 15 and 50 years old are different in Syria, for example, than they are in Kuwait. And if you look versus males versus females, you can also see those disparities. And since this was done in 2013, then that explains why males in Syria are dying much more, even almost 3 times higher than females. And that is because this was at the top of the peak of the civil war and the hostilities that were happening. But again, this is just to give you an idea about when we talk about equity and disparities, then the Arab world within itself is also suffering from inequities when you move from one community to another and from one country to another. Next. If we look at the major determinants of inequities, and these are 3 case studies of Syria, Tunisia, and Morocco, that as you can see, that darkish blue is the most important thing is household wealth. So poverty and income are going to be very much related to why some people have better health than others. Next slide. And even within the same community, within the same country, again, income is a major player. So in low income, we are still seeing the traditional communicable disease causes of death and disability amongst females. If we move across to middle income and higher income, then we're starting to see NCDs, which are more similar, and they mimic what we see now in Western societies or in more developed societies. The same applies for the next slide. The same applies for males. although we see that in high income, road injury is the top one in death and disability. And that is because in the Arab world, not everybody can afford a vehicle. However, if you're rich, then you can have a vehicle, and it's probably a top model with high speed. And due to the policies and lack of free enforcement, the road injuries among the high income Arabs is one of the causes of death amongst males. Next slide. So shifting gear a little bit to cover what we that Maha alluded to as the refugees. So the region has been very well known for political turmoils as well as armed conflict. However, since 2010, we have seen a lot of places that have been experiencing more and more. This is a picture of the Yarmouk refugee camp in Damascus, and that is this picture has won the photography award because this is people waiting in line to receive food support after 3 years of siege of the camp, and they say a picture is worthy or better than 1,000 words. So I won't dwell on this. But let's go to the next slide and talk a little bit about the refugees. There are chronic problems. The Palestinian refugees have been experiencing refugee status for now more than 65 years. And if we look at Lebanon, for example, there are 12 refugee camps in Lebanon, and they have been there since almost 1948. And if we look at some of the determinants of health among that population, and specifically in Lebanon, because there are strict rules to what Palestinian refugees can provide and cannot provide, or can work and cannot work in. I'm sorry, I just looked at the text. So as you can see, most of those that live in the refugee camps in Lebanon, the Palestinians, and now some of the Syrians are living under the same conditions. They never work and they're not looking for work, and their main source of support is whatever the UNHCR is providing them, which is very minimal based on their needs. Next slide, please. This was one of very few studies that they're not looking for work because in Lebanon specifically, they are not allowed to work. There are 71 occupations that a registered Palestinian refugee cannot work in. And if we look at, there were other slides that I'll be more than happy to share later on. There are slides of education and higher education. Very few of them do not have the higher education to get them a job, and many of them work either in unskilled labor or skilled labor, or they're unemployed. The only place they can work in is within the refugee camp, and that tells you that it is very hard to get there. So going back to, this was a study that was done on children that were living in refugee camps. We visited 4 refugee camps and took anthropometric measurements of almost 300 children that were apparently healthy. They range from birth till almost 12 years of age. And we have seen a protective factor until 2 years old because most of those were breastfed. But once they were weaned off between 2 years and 12 years, we saw a difference in the head circumference, weight, and height Z-scores. They were significantly less than what the enhanced data shows. And when we linked it to a food security questionnaire, such as meat and fruit consumption, we found out that they were correlated negatively with weight and height. And it again shows that even within the same country, refugees are at higher risk for inequities and disparities in health outcomes and health status. Next slide, please. Then you have the acute refugees that we have been dealing with, specifically the Syrians after the Syrian war or revolution or hostilities, whatever you want to call it. But we have seen differences in the countries where refugees are living, specifically in Jordan, Turkey, and Lebanon. This was a study that was done on the refugees in a Zatari camp in Jordan, where they looked at youth and adolescents and their mental status, and 85% are worried and they have fear about the way they are living in the camp life, and then almost 65% feel they are not safe, and that is leaving a lot of trauma and a lot of unnoticed, specifically among their parents, unnoticed psychological trauma and mental behavior that they are manifesting later on. Next slide, please. Okay, and again, the same applies to things such as access to information and access to public health. This was a study that was done by Dr. Nowen from MSU and colleagues in Jordan and in Turkey and in Lebanon. And this was just understanding, it was done during COVID, understanding what people that are living in refugee camps feel about COVID and the level of protection. Even staff working there were subscribing to some of the conspiracy theories. But as you can see, the refugees, almost 20% believe that COVID is not real and it's exaggerated. And the staff believe that this is a government tool to treat refugees poorly and so forth. So again, there is a need to look at that population in terms of the information that they receive and in terms of prevention and in terms of awareness. Next slide. So my last piece is about those that immigrated. And as Maha said, these are people that decided either by choice or they were forced due to economic or political or religious reasons to leave their country and seek home elsewhere. And in this case, we're talking about Arab Americans. So although they are carrying with them the all traditional social determinants of health, there are added social determinants of health that are only specific to those immigrants and those people, such as language barriers, such as cultural beliefs, access to care. Discrimination is a big thing, as well as the journey that they took in terms of migrating, whether they came at a younger age or whether they came at an older age, how long they have been, their refugee status, what they have encountered during the journey. Have they been flooding war, and do they have any PTSD and depression and issues? So that compounds an already existing desperate system or that is adding to the social determinants for that population. Next slide, please. There has been a study that was done by Dr. Al-Sayed and colleagues where it shows that there are inequalities or inequities in mortality in Arab Americans, that they live, whether males or females, they live shorter than their white counterparts, and they are at higher risk for cancer and diabetes and others. And this is something that Dr. Jaber, I'm sure she's going to talk about when we talk about diabetes as more prevalent in Arab Americans. And despite that they come with better education and possibly higher income, there is still a higher age-adjusted mortality, which might be explained by either some of the socio and discriminatory practices that those Arab Americans feel or those immigrants feel. Next slide. There has been only two Arab BRFSS surveys that were done in the state of Michigan. And although they provide great value, it is still incomplete. But one of the data that showed that in overall, the Michigan Arab Americans are poorer than Arab Americans living elsewhere in other states. And because of that, they are poorer than the state standard as Michigan overall. And because of that, they are more at risk, such as other ethnicities, to display some of the disparities. Next slide. Such as their estimate or their what they perceive as their general health, and also no health access due to cost. If we look at Arabs, which is the one on the right, then they are very close to African Americans in terms of the percentage of those that believe that they are in poorer health or that they are not seeking healthcare access due to cost. Next slide. And if we stratify it within Arab Americans, then again, that disparity based on the socioeconomic status and education status and household income become very evident that even within the Arab American communities in Michigan, you will see inequities and disparities based on education, based on gender, and based on household income. Next slide. These are some of the 2016 Arab BRFS. And as you can see, Arab Americans compared to Michiganders are lagging behind in preventive and behavior, and they also are more probably at risk for some chronic conditions, and specifically some healthy risk behaviors such as lack of physical activity and smoking, specifically hookah. Next slide. So to summarize everything, and I'm sorry if I zap through it very quickly, we talk about the determinants of health as a universal thing, and these apply to health equities in the MENA region, both across the region and also within the countries. These determinants are amplified in poorer countries versus richer countries, and specifically in vulnerable populations such as the refugees. And those that come from those countries, specifically the first migrants and first generation, they carry these disparities and beliefs that will be displayed at least in the first generation of Arab Americans that are here in terms of their health behavior, health belief, and in their health outcome. And something that I'm sure Madiha is gonna wax poetic on, which is data availability or lack of data. Data stratification has to document Arab Americans as an entity so we can understand those disparities and those inequities, and we should incorporate that in every intervention and program and solution as we address this population. Thank you very much, and I hope this was useful information for all.